Hello, welcome everyone to this Tuesday evening's webinar. It's the first one of the year, the joint one between the American Society of Head and Neck Radiology and the European Society of Head and Neck Radiology. Just going to, before introducing the moderators, we're just going to wait for people to filter in as it takes a little bit of time on Zoom. So just as that's happening. And I'm just going to give a little bit of a background. This year, we've got a different angle. We've got about 4 or 5 webinars planned. And the angle will be, we're going to have a clinical colleague joining us. So we're going to do sort of a clinical correlation, that famous phrase, clinical correlation between a radiologist and their clinical counterparts. So this today's is going to be from the European side, where both speakers are from the European side, and then we're going to alternate plan going forward. So let's carry on now. I'm going to introduce you to our moderators. Hugo Tames from Sao Paulo, Brazil, currently in Brescia, Italy, and Phil Touska from London. So take it away, guys.
Hello, so I'd like to welcome you, whether you're from North America, Europe, or anywhere around the world. Welcome, bem-vindos. Next slide, please. So you can use the Q&A panel to ask questions for the presenters to answer following the presentations. And you can use the chat box to discuss and connect with your fellow attendees. If you don't want to see the chat alerts, you can minimize the chat box in your Zoom control panel. Next slide, please. So you can collect CME credit. They will be available for all webinar attendees through the ASHNR Education Connection website. If you don't have an ASNR login, you will be asked to create one. Next slide, please. And the learning objectives is to gain knowledge of the major changes in TNM-8 classification, particularly in relation to HPV-associated oropharyngeal cancers, oral cavity, and nasopharyngeal cancers, to understand the prognostic implications of HPV-related oropharyngeal cancers, and to understand the strengths and weaknesses of imaging modalities in predicting extranodal extension and depth of tumor invasion. None of the faculty and planners have anything to disclose. Next slide, please. And we would like to invite you to the ASHNR 24 annual meeting. It will be held in San Diego from September 4 to September 8. So I'm definitely going. So we would like to invite you and save the date. Next slide, please.
Thank you, Dr.
And now I
Tames.
will pass on to Phil. Yeah.
Thank you. Hi, everyone. I'm going to make a few brief announcements before we move on to the speaker introductions. So I'm delighted to announce a new tie-up between the American and British Societies of Head and Neck Imaging. So Dr. Gitta Madani, who will be lecturing us today, will be the first visiting professor and will be touring institutions in the USA. So those of you the other side of the pond, please do look out for her. We would also like to extend an invitation to Sweden, to Malmö, for the next ESHNR annual meeting that's going to be taking place, and it's going to be a fantastic program. If we can move on to the next slide, please. We also have a couple of upcoming webinars, including a very practical session on paranasal sinus imaging by Dr. Raniga from Oman, moderated by Dr. Hirvonen from Finland, and that's on the 26th of March. Next slide, please. And we have next Tuesday, we have a tie-up between myself and Professor Leon van Rensburg from sunny South Africa, moderated by Dr. Lennart Fligare from Sweden. And if we can move on to the next slide, please. Please don't forget to follow both societies on X. Next slide, please. Without further ado, it's a pleasure and an honor to introduce 2 esteemed colleagues from London who'll be providing a radiology surgery double act today. So we have Mr. Zaid Awad, who is a consultant otolaryngologist and head and neck surgeon based at Imperial College Healthcare NHS Trust. He's trained at various centers of excellence in advanced head and neck surgical techniques, including robotics, and has served on national committees, including the Specialty Advisory Committee of Otolaryngology and the ENT UK Council. He has strong research interests, including looking at quality of life, patient safety, advanced operative technology, training, and education. He completed a PhD in simulation and assessment in ENT training at Imperial College London and has multiple articles, book chapters, and prizes to his name. So we also have Dr. Gitta Madani, who's a consultant radiology, head and neck radiology colleague at Imperial College Healthcare NHS Trust. She's a senior lecturer at Imperial College London and active in teaching and training, lecturing both nationally and internationally. She has research interests in various aspects of thyroid ultrasound and intervention and has been involved in multi-center trials in these areas. She has previously been a committee member of BSHNI and, of course, is the current and first ASHNR BSHNI visiting professor. She's authored several book chapters, peer-reviewed articles, and national imaging guidelines. So without further ado, I shall hand over to Mr. Awad and Dr. Madani.
Thank you very much, Phil, for the kind introduction, and thank you for both societies for the invitation. It's an honor to be here and see some old and current colleagues. I hope you find the session useful. Next slide, please, Peter. We're going to start with a bit of history. So the Union of International Cancer Control was founded by researchers in 1933. The TNM was developed after that between 1943 and 52 by Professor Pierre Denoy at the Institute of Gustave Roussy in Paris. And the first edition was published in 1968 as the Pocket Book of Classification. The American Joint Committee of Cancer first published a separate definition to the TNM categories based on the UICC in 1977. And it wasn't until 1987 when both developed a joint TNM staging system. Initially, the staging was anatomically based, but the principles are, obviously, as you know, T is for the primary, and N is for the nodes, and M is for metastases. After that, everything evolved a lot in the past 50 years, and certain important additions were made in those 50 years, including the addition of histological grading into sarcomas and bone, as well as prostate tumors, obviously age and histology into thyroid tumors to separate them prognostically, and serum markers into other cancers. The UICC developed a mechanism for continuous improvement of the TNM classification. And over the years, there's a standardized review of any proposal for change and a watch out for literature for everything to be incorporated into the next edition. Site-specific panels were developed and established internationally to review all the evidence and guide the process of development. The main aim of the TNM system, as we know, is to give an idea about prognosis. So it helps us when we talk to patients regarding their prognosis, but also in terms of selection into different arms of treatment when there are different treatment options. More importantly, it's also important for recruitment into research trials and comparing outcomes between different units in same countries, continents, or across the world. So the system has to be easily reproducible and comparable, and also has to be available to all those across the world. And this is why you see sometimes that advanced imaging technology may not be first on the list for staging cancers in the TNM system. The prognostic age groups, which tend to be split in terms of, or reasonably equally split in terms of numbers or percentages of patients. As you know, stage 0, where there's no cancer or carcinoma in situ. 1 or 2 tends to be the tumor which is localized to the organ of origin. This is obviously very generic and applies to all cancers. And then stage 3 is either locally very extensive or has spread into regional nodes. And obviously stage 4, which can sometimes be subdivided into different substages, involves distant metastasis in most occasions. The TNM-8 came after the TNM-7, which was published in 2009. I know that it required a lot of work and a lot of discussions and several meetings from knowing people that were involved in its development. And it was first published in December 2017 and caused a lot of controversy. It was eventually adopted by most cancer registry systems in the UK by the end of 2018. However, clinical trial committees decided to stick to TNM-7 for recruitment purposes, as most of those trials were in development during the TNM-7 time, and also they were still not sure whether changes to the staging system should affect trial recruitment. Treatment de-escalation is still a controversial issue, and we will touch on that. The major modifications in the 8th edition include adding tumor thickness as a pathological feature, mostly for oral cancer, in addition to the pre-existing size staging. Also including pathological characteristics of cervical lymph nodes to the end staging, where now extranodal extension is included in the staging system. The most important and the probably biggest change is the incorporation of the viral status for HPV positive or P16 positive cancers in oropharyngeal tumors, which has a big impact on prognosis. And also, which causes a little bit of confusion, which is the differing pathological and clinical staging criteria for cervical lymph nodes. The new stage classification for HPV related oropharyngeal cancer, as mentioned a minute ago, soft tissue sarcomas of the head and neck are also different in terms of the T staging, as well as the overall staging and age for thyroid cancer. There's now a modified T stage for nasopharyngeal cancer as well, oral cavity, squamous cell carcinoma, depending on the thickness, and head and neck cutaneous carcinoma, which now falls in line with the rest of the upper aerodigestive tract cancers, unlike other skin cancers. The N stage classification, as mentioned a minute ago, for the unknown primary is now depending on the viral status of the biopsy taken from the neck node. And as mentioned, there is a separate classification for clinical and pathological end node and the inclusion of extranodal extension.
So I'm going to take over. HPV positive oropharyngeal cancers generally occur in the younger, healthier individual who have little or no tobacco exposure. And it's generally highly responsive to treatment with a really good prognosis. The old TNM7 staging had lost its ability to discriminate between stages and was no longer of highly predictive value. In order to be useful, the TNM staging needs to show different survival between the different stages. So each stage must have a different survival from the one above. That's called hazard discrimination. And there should be roughly equal number of patients in each stage, and that's called balance between groups. So it was important for the HPV positive subgroup to become a distinct clinical entity, and that might facilitate future de-escalation of treatment. We've known this information for quite some time. This study from Wales in 2013, it's a relatively small number, but shows a very large difference in survival between HPV positive patients who have 92.6% survival at 3 years versus the negative patients who have less than a third of whom have survived at 3 years. So the development and validation of the staging was through the ICON-S trial, which many of you will be very familiar with. This was a 7-center trial with 1,907 HPV positive cancers. And it found that TNM stages 1, 2, 3, and 4A had fairly similar 5-year survivals between 88 and 81%, although the 5-year survival for stage 4B was lower. And that the 5-year survival was also similar amongst the N0, N1, N2A, and N2B nodes, ranging between 80 and 87%, but significantly lower in the N3 disease. TNM7, T4A, and T4B also had fairly similar survival. So through this information, the new TNM stage 8 with TNM 8 stages were derived, and the N classification now for the HPV positive cancers is actually very similar to the nasopharyngeal cancer classification, but without the lower neck node involvement criteria. Since incorporation of TNM8, there's been validation studies. So this was basically a validation of the pathological classification of lymph node metastases in head and neck cancers. And it was a retrospective study of nearly 1,200 head and neck cancers who had had neck dissections, and found that incorporation of extranodal extension in TNM8 improved prognostic capability. Back to you, Zaid.
We're going to look at the changing with the oropharyngeal cancer, squamous cell cancer first as the most important. And in terms of the T staging, there isn't really much difference in terms of T1, T2, and T3. As you know, it all depends on size, as long as it is still restricted into the oropharynx. The involvement of the lingual surface of the epiglottis is still there as upstage to T3. The difference is that there is now no differences between T4A and T4B when it comes to P16 positive oropharyngeal cancer, i.e., even in cases where the carotid is encased or there is invasion of the prevertebral fascia, which used to be sort of negative prognostically, are now combined into the same T4. In terms of the nodal stage, this is where some confusion arises. In terms of the P16 positive cervical lymph nodes staging, so N0, no nodes, N1 is unilateral metastasis in a number of nodes, all under 6 centimeters clinically. So compared to the P16 negative, obviously, as you know, if it's more than one node, it's N2, and then the A, B, and C. While here N2 only corresponds if it's more than 6 centimeter contralateral or bilateral nodes, still under 6 centimeter, and any nodes greater than 6 centimeter is considered as N3. While pathologically, up to 4 nodes is still included in N1, while anything above 5 nodes is included as PN2. And here, extranodal extension or the size of the node does not come into the staging on the pathological stage. To put it into context with regard to the staging, the P16 negative is effectively unchanged, while for the P16 positive, only distant metastasis will make a tumor a stage 4, and irrespective of a T4 tumor, for example, or N3, which would make a P16 negative tumor stage 4, as well as the metastasis. In P16 positive tumors, it's only the distant metastasis that will pull it into the stage 4 category, while T4s, large tumors, or N2 or even clinically N3 would still be considered as stage 3 disease. Next, please. The cervical lymph node metastasis in everything else, excluding HPV positive and nasopharyngeal cancer, is effectively only changed in terms of the extranodal extension. And clinically, extranodal extension is identified by skin involvement, soft tissue invasion, deep fixation or tethering, and that could be assessed clinically, and then would be labeled as N3B. Everything without extranodal extension is unchanged and depends on size and laterality. And the pathological staging is again the same, but extranodal extension would push the patient into N3B category, and that would then impact the overall staging of the disease into being a stage 4 disease, and that's reflected on the prognosis as well.
So, as Zaid said, extranodal extension is basically judged clinically or pathologically, but radiological assessment of extranodal extension has been removed from the TNM staging. So how good is imaging at looking at extranodal extension? Well, this systematic review and meta-analysis by Su et al. Showed that actually radiology is reasonably sensitive to extranodal extension, with MRI being better than CT and ultrasound being better than MRI, and specificity reasonable also in the 80s. But as we said, it's been removed from radiological assessment. Sometimes we can see it very clearly. I mean, this one, you would also be able to assess it clinically with invasion of the sternocleidomastoid, notably on TNM7, this would have been N2B plus extracapsular spread, and the treatment would have been surgery plus or minus postoperative adjuvant treatments. And for TNM8, it would be TN3B, and the treatment would be primary chemoradiotherapy from the outset. Back to you, Zaid.
Thank you. For the unknown primary, if they are EBV positive, and that's now recommended to be one of the first tests that we do for patients presenting with neck lump without any clearly identifiable primary on the clinical examination, and the first stop being an ultrasound-guided fine needle aspiration cytology, then EBV status and P16 status is essential. If it's found to be EBV positive, then we stage it in a similar way to nasopharyngeal cancer, and we'll come to that in a minute. If it's found to be P16 positive, then we stage the neck as the P16 positive oropharyngeal cancer, because most of these cancers, not all of them, would have started in the oropharynx, and that was explained in earlier slides. Now, the viral status can be obtained from FNA fluid cytology, assuming there's enough cell block to do that. It's not always possible, so a core biopsy is, at least in the UK, is now quite popular, and in our unit, we use it a lot to do the P16 as well as the HPV status, and we know that the correlation between the two is also important. This also allows us to add, for example, for patients eligible for trials or immunotherapy, to do PDL, CPS scores, and enter eligibility for clinical trials. In terms of the nasopharynx, the T stage is slightly changed, where now there is no T2A and T2B. In fact, T2A has been incorporated into the T1. So basically, the nasopharyngeal tumor, which extends into the oropharynx and or to the nasal cavity, as long as there is no parapharyngeal space involvement, is considered as T1. The rest is unchanged in terms of the T staging. In terms of the N staging, unilateral metastasis, irrespective of the number of cervical lymph nodes or retropharyngeal nodes, is considered as N1, while N2 is bilateral metastasis as long as it's less than 6 centimeters and it's above the caudal border of the cricoid cartilage. This is now used as a different term to supraclavicular nodes, and then it would include central compartment nodes, and it will be a clearer anatomical landmark on radiology as well. And metastases in cervical lymph nodes which are greater than 6 centimeters or that fall below the caudal border of the cricoid would be considered as stage 3 or N3. In terms of oral cavity, depth of invasion has been added, and that's been an important addition and very helpful addition. And it's very important to distinguish this from tumor thickness. The depth of invasion is the depth of the tumor from the nearest normal tissue. So we need to establish a horizon at the level of the basement membrane relative to the closest intact squamous mucosa, and then measure the depth according to that. In ulcerated or deep tumors, the depth of invasion will be less than the tumor, will be more than the tumor thickness, and it's the other way around in exophytic tumors, which can be clinically misleading. The depth of invasion, if it's less than 5 millimeters, that falls within the T1 stage, as long as the diameter or the greatest diameter is still under 2. So the diameter or the surface diameter is unchanged, but the depth has been added to that. And any of those criteria would upstage the T stage of the tumor. T2 would include anything less than 2, but between 5 and 10 millimeter in depth. And T3, anything above 4 or above 10 millimeter in depth. And T4 for anything advanced. And the A and B has not really been changed, and that includes involvement of the structures shown on the slide. But more importantly, 4B would include masticator space, pterygoid plates, skull base, and encasement of the carotid artery.
So, Zaid mentioned depth of invasion versus thickness, and we're going to look at whether imaging has a role. And I'm going to present a few studies here because there's quite a lot of conflicting data. So early studies suggested that CT and MRI measurements of depth of invasion in oral cavity squamous cell carcinoma lead to an overestimation compared to the histological depth of invasion, especially with smaller tumors less than 5 millimeters. And a substantial number of patients can, of course, have artifact on CT and MRI due to dental restorations. So other studies have looked at which MRI sequences to use. This study by Lee et al. Looked at, did a meta-analysis and concluded that actually the T1 estimated depth of invasion is quite similar to the histological depth of invasion, but on some sequences, peritumoral edema can result in overestimation. Other studies have looked at early phase volumetric dynamic contrast sequences and suggested that that might be the best way to measure it. And there are studies which correlate the MRI depth of invasion predicting occult lymph node metastases in clinically N0 T1 tongue SCC and predicting increased risk of recurrence and cancer-related death. And as you know, there are various studies that show histological depth of invasion is an independent predictor of survival. So this shows that actually radiological depth of invasion may also play a similar role. Ultrasound is probably more accurate than MRI in predicting depth of invasion in some studies anyway. And the mean difference between ultrasound and histological depth of invasion in small tumors, T1 and T2 tumors in one study was 0.5 millimeters. I think some of the confusion about the depth of invasion came from the way people measured it. I think this study started to look at why depth of invasion was being overestimated. This diagram, though, does not demonstrate it very well. It does show you what it considers to be the depth of invasion versus the thickness of the tumor. And of course, ultrasound has challenges such as ulceration and discomfort, which you can overcome with local anesthetic sprays and gels, doing it under general anesthetic, and access to certain parts of the oral cavity. But again, local anesthetic gel tends to help with that, or spray. I think this study by the Italian group that we know very well is the most elegant, actually, which compared depth of invasion in the oral cavity on MRI with ultrasound and histopathology. And the diagrams demonstrate it very well. If you have an exophytic tumor, you need to basically go from mucosal surface to mucosal surface and not overestimate the depth of invasion. And of course, if you have an endophytic or ulcerative tumor, you should again do the same thing and not underestimate depth of invasion. And the ultrasound and MRI findings correlated very well on this study. And that's exactly what I do. Here's, for example, a posterior oral cavity tumor. You can see on MRI, the depth of invasion is about 11 millimeters. It's quite difficult to get to the back part of it and keep it in one image. On ultrasound, you use a very small footprint probe, cover it with jelly, and then put a condom on it, dip that in some water, spray some local anesthetic in the area so that the patient doesn't gag when you're going to the back towards the back of the tongue. And the correlation between the two was very close. Back to you, Zaid.
The differences in sarcoma staging now looks more like, again, head and neck classification. So size is now important. So we've gone to 4 stages of the primary. Less than 2 centimeters will be a T1, between 2 and 4 will be a T2, more than 4 centimeters will be a T3, and T4 is when it invades adjoining structures. So orbital invasion, skull base or dura, central compartment viscera, and facial skeleton or pterygoid place will be a T4A, while brain, parenchyma, carotid artery encasement. So similar to the rest of the head and neck staging that we are used to. N category remains as binary, as either with or without nodal involvement, and M category staging is the same with 0 or 1. It's very important that we reiterate the viral status of tumors and obtain this very early when patients are diagnosed with cancer, to do this on fine needle aspiration cytology, usually ultrasound guided in most places. It has a very important predictive value. And just to give you an example, while previously a 2 centimeter P16 positive tonsil cancer with 2 positive ipsilateral nodes in TNM7 would have been a stage 4 disease, and now considered stage 1 disease in TNM8. It has obviously excellent prognosis, so these people are expected to have a 5-year survival, approximately 89 or 90% if they're P16 positive, but obviously if they are P16 negative, then that drops significantly. It helps with diagnosis and psychology of the patient too. In terms of the unknown primary, as mentioned before, we do P16 staining and EBV staining for all unknown primary tumors, and that can be obtained from liquid cytology. And if not, then proceed with a core biopsy, which is becoming now more and more popular, depending on the service you have. And we tend to avoid lymph node excisional biopsy whenever possible. There is some change in the name, so T0 is usually used for the viral mediated unknown primary after excluding all the minimal investigations, which include clinical assessments plus biopsies and PET-CT. We also did some work on the role of MRI scan recently, which we tend to use in our unit, but it's not currently within the TNM staging guidelines, while TX is used for any unknown primary of other subsites. In terms of the nodal status, the difference between clinical and pathological staging can be a little bit confusing, as there is no N3 disease in pathological staging. And this relates to the fact that patients have better prognosis, and they will still be at stage 3 disease at most, and have considerably better survival than P16 negative. There is, however, an implication for understaging of sort of surgically treated disease. For example, for certain trials, or in some units like ours, where robotic assisted surgery is used versus chemo and radiotherapy, that patients will have a lower overall stage, as we then know the pathological stage of the lymph nodes. While in the HPV negative, the extranodal extension, which sometimes, not always, especially if it's very early, can only be identified on post-resection specimens, is found after an operation, and then that mean technically you've operated on somebody who has stage 4B disease and is potentially surgically incurable. The oral cavity, which we mentioned, the difference between pathological and clinical staging, where the depth of invasion is now very important. We can potentially understage patients who are unfit for surgery. The issue is that most oral cancer patients will undergo surgery, so then the actual depth of invasion can be measured, because we're going to do a resection with a nearby normal margin. And then most of the times we worry about sort of overstaging, while those who don't have an operation and may end up having primary radiotherapy, which is not the first line of treatment in oral cancer, but for any other reason, we do not have the benefit always to assess that on histology. So this is where the role of radiology and clinical assessment becomes important. And now when we do oral cavity biopsies, as we still avoid sort of excisional biopsies, we tend to do a biopsy that includes an edge or a rim of normal tissue around it to assess the depth of invasion. Just to touch on thyroids, as we mentioned that in the beginning, there are two main changes in thyroid staging. The age of good prognosis has been increased from 45 to 55, where patients can only have a maximum of stage 2 disease. So effectively, any T with any N, as long as there is no metastasis, is considered as stage 1 disease, and any patient with distant metastasis is considered as stage 2 disease. The other change is the abolition of stage 4C, which means everything is pulled upwards. We're now T1 and T2 thyroid, differentiated thyroid tumors are now included within stage 1, while T3 is now stage 2, while previously it was stage 3. T3 or N1 would be stage 2. And then T4A with any nodal metastasis, as long as there's no distant metastasis, is considered as stage 3, and T4B would be stage 4A, and patients with distant metastasis would be stage 4B. But the way I remember it is that there is no stage 4C, and everybody else has been sort of moved into a better category, and that reflects the overall excellent survival of thyroid cancer. Other important implications, as you may know, for those of you who work in units that recruit to clinical trials, like we do, that clinical trials still use the TNM7, partly because the trials were developed or the protocols were developed around the time of the publication or before that, or for the TNM8. And secondly, because there is still some skepticism regarding changing of treatment. One of the most important things to remind ourselves of is that all those data that we showed earlier about the better prognosis of P16 positive patients is built on the fact that those patients still had the standard treatment, for example, of chemo and radiotherapy. Before sort of the role of the robotic assisted surgery, when transoral surgery was only reserved for those who are unable to have chemotherapy, for example, or for salvage cases, we didn't have to have that discussion. But nowadays it's very important not to de-escalate based on that data, because those patients who had a good outcome had a good outcome because they had the same aggressive treatment that the P16 negative patients had, if you see what I mean. There is also the risk of stage migration. So basically, although the updates in staging more accurately reflects the prognosis of patients nowadays, sometimes positively, like the P16 positivity, or sometimes negatively, like the extranodal extension. However, when patients with the same disease migrate into a different stage, it becomes very difficult to compare that with historic data. And for some time, most units collected both and recorded both staging according to TNM7 and TNM8, and we still do that occasionally, but we are moving away from that. Thank you. We'd like to thank my colleague, Mr. Alistair Mays, consultant head and neck surgeon who works with me at Charing Cross Hospital in preparation of those slides. And thank you all for listening and for the invitation again.
Thank you very much. That was a fantastic and very clear talk. Thank you, both of you. So I'm just having a look at the list, and we don't have any questions yet, but there'll be a little time for questions to come through. But if it's all right, Hugo, I've got a couple of questions I can start with, and then maybe got one for Zaid with regards to TORS. Can you provide a little bit of context and comment for radiologists in terms of what might influence your decision-making in terms of which patients are TORS candidates versus which aren't, with regards to sort of oropharyngeal SCC?
Thank you. It's a very good question, which we still go through every meeting. So initially, when we started, I think most units started, and that follows the guidelines of not to change treatment unless it's within the context of a trial. So we recruited patients to Pathos trial, and some other countries are familiar probably with Orator or the 1133, if I remember the name correctly. So following the trial criteria would normally include smaller tumors. It can go up to T3 of ideally sort of tonsil or tongue base, preferably lateralized, but not essentially. It does not cross the midline with low risk disease. So, for instance, no extranodal extension and no contralateral neck nodes, no retropharyngeal nodes, and obviously no metastasis. So in general, smallish primary, which should ideally undergo an assessment under general anesthetic to confirm resectability, with disease limited to the neck, which doesn't have any aggressive features. With time, things changed a little bit because we learned from our practice, and even outside clinical trial, for example, we offer it to patients who cannot have chemotherapy. In some areas, we become more confident, and in some areas, we became more careful. For example, we look at the invasion to the constrictor. If disease is through and through the constrictor, even though there's no clear invasion of the parapharyngeal space, I'd be very worried about ending up over-treating the patient, because if I remove a tumor and then we look at the pathology and the margins are positive, you'll end up giving the patient chemo and radiotherapy. So triple modality treatment for a disease, which is technically we're talking about HPV positive disease, disease which is quite easily curable and has good prognosis with the standard treatment.
Thank you so much. That's really helpful. And that's a good point, because obviously the constrictor muscle involvement isn't part of the TNM stage, doesn't sort of upstage it to T4. So something that's sort of worth us bearing in mind as radiologists. So I have a quick question for Gitta, if that's all right. So the AJCC8 TNM staging had sort of advised that it's clinical only in terms of calling extranodal extension. But obviously there's a lot of interest often in MDTs about suspicion of extranodal extension with regards to aggressiveness of treating. Do you have any sort of comments or advice to sort of radiologists looking at MR in the context of extranodal extension?
Yes, I mean, I think it's obviously if you get muscle invasion, that is a sure sign of extranodal extension. I think the boundary of the node, how regular it is, and how it interacts with adjacent structures is also very instructive. There are lots of pathological studies that suggest actually that once you get past a 4 centimeter size in a node, that's really got a high sort of positive predictive value for extranodal extension. Obviously doesn't make it a radiological one, but the bigger the node is, the harder you should look at every boundary. Be mindful whether the patient's had some ultrasound guided core biopsy or a blind core biopsy, because that's obviously going to change the appearance of the node in certain areas. And we look at it very carefully and we document it. We don't allow it to change our staging, but we do pay heed to it. I mean, I don't know what you feel, you feel, Zaid, it might change our management, particularly as so many patients may have non-surgical management.
Yeah, I think it also, I'm very lucky. I have excellent radiology colleagues, and I take what they say very seriously. And like I said, when in certain cases, it's not going to affect the outcome. If the patient is HPV negative, they're going to have chemoradiotherapy. It's more of a prognostic indicator. You're not going to change much. For those who we select for surgery, I take it very seriously, because as I said earlier, the last thing you want is to escalate treatment. And when you do, although this is not published, this information will come later. It has a significant impact on functional outcomes, because you end up over-treating patients. Occasionally, you do get caught. And the flaw in that staging is that there is no grading to the extranodal extension. There are some papers that looked at that, and it's thought to be that grade 1, which is not identifiable clinically or radiologically, that's based on CT criteria, which is not fantastic, is not clinically relevant and is not prognostically relevant. But then when it goes to grade 2, which is outside the node, or stage 3, which is into surrounding structures, then this is, I think, what the TNM is trying to include. But we're not really there yet. And because we're not there yet, everybody hears extranodal extension and they think immediately of chemotherapy.
Thank you very much. That was extremely instructive. Hugo, do you have any questions?
Yes, I have one question for Gitta. I saw your images of the depth of invasion, and are you using it regularly, providing the reports? And which sequence do you find it better? I saw you show the reference saying T1, but I'd like your opinion.
For depth of invasion, I tend to look at post-gadolinium sequences, T1, and compare it with ultrasound. But I think the reality is it's a guide, because most of the oral cavity cancers then proceed to have surgery. So we will end up having a pathological depth of invasion. But we find that we're actually reasonably accurate. It's unless someone's had quite a big biopsy before you're doing your imaging, we find that you actually are we're getting reasonably accurate information. And we tend not to do dynamic contrast enhanced. So I just tend to do on a contrast enhanced study that is of whatever time scale that happens to be in that MRI scanner. And it tends to correlate reasonably well to the T1 still.
Again, it's if I may add, it's obviously mostly for the superficial tumors. When it becomes quite deep, and those that get flagged at the MDT, I find sort of MRI is quite useful if there is no artifact and the patient hasn't moved and all that, and no amalgam. We've had few patients when you can easily get caught and CT scan wouldn't identify it. We don't do ultrasound routinely for the tongue, mostly probably due to lack of resources. But occasionally when you see something small, but there is a tail to it that extends very close to midline, what it is, it's kind of quite helpful to go through those images with the radiologist, because it does affect the resection, and sometimes it's not really easily palpable. And it's a very different planning process if we're going to go close or beyond the midline of the tongue in terms of reconstruction and the functional impact for the patient.
Thank you very much. There are some questions, I think, from our audience. Hugo, did you want to read one of them out?
Okay. Great question. What should we anticipate for AJCC9? When will changes for head and neck come out?
Ooh,
gaze into the future.
Yes. I don't know how frequently the AJCC actually updates. So do you know? It's quite variable.
It's very variable. It depends on the evidence. I think there's certain things that we just mentioned. I think potentially the classification of the extranodal extension is going to be probably something to include. And the fact that 2 trials that attempted to de-escalate treatment, it might be a minor modification, because they're not all as major as the TNM8. For instance, the de-escalate trial and the other American one, the RNTOG, which one is it? 1016, which de-escalated from cisplatin with radiotherapy, 4p16 positive tumor, down to cetuximab and radiotherapy, both published at the same time. The American European trials, both published maybe end of last year or last year, and both showed inferior results with cetuximab versus cisplatin. So maybe there'll come a modification to say that although this is affecting prognosis, then treatment should not be changed. Maybe clearly state that treatment should not be changed outside the context of clinical trial. And we don't do it, although we record all that, but we don't, for example, spare people postoperative radiotherapy if they have N1 disease following robotic-assisted surgery and neck dissection with low-risk features outside a clinical trial. And those who are in a trial, they'll get randomized to that. And luckily, we didn't really get many of those. We had some that, and those who would need chemotherapy, i.e. have extranodal extension or have contralateral disease, high-risk features, or have positive margins, we still give chemotherapy, and we did not recruit to the high risk arm either. So most of our patients, if people are familiar with recruitment into Pathos or ECOG 1133, or which are very similar for P16 positive patients, we ended up recruiting into the moderate risk group, where basically all you do is you reduce surgery and then reduce the post-operative radiotherapy from the standard 60 gray to 50 gray, which I think is quite reasonable. It's the standard radiation dose in many other cancers, and it works fine for microscopic disease. But we didn't get many low risk patients, and we didn't recruit any high risk patients. And I think the results will show. The European one already published. Pathos is still open for recruitment, but I think the finding will be that reduction of radiotherapy is good. I'm not sure about omitting chemotherapy, and we'll wait for the results.
Thank you very much. 3 more questions, then we'll probably have to close the external questions because we're running up to time. But there's a sort of quick one for Gitta, I think sort of on the basis of talking about extranodal extension. How often do you recommend MRI in that context? I'm assuming it's from someone who probably uses CT as their primary staging modality. I suppose most of us here would be using MR for oropharynx, wouldn't we? But
yeah, we tend to use MRI wherever possible, really. Sometimes we have time constraints and we only get a CT. Sometimes patients have a PET CT and actually it wouldn't change very much what we're going to do, and we would skip the MRI. But really, if staging were critical, we tend to use MRI anyway. We tend to ultrasound most necks, and actually, whilst we often don't, so Zaid was saying we don't often ultrasound the oral cavity. If we're ultrasounding the neck, we tend to try and to ultrasound any accessible oral cavity, any accessible aerodigestive tract tumors, and just verify its staging. So we don't have a kind of rule on that, but we do tend to just slot it onto our normal ultrasound neck. So our default would be MRI with ultrasound neck. It doesn't always work like that, if I'm honest. There are many compromises that we make, but our default would be MRI and ultrasound.
Thank you. And I think the last 2 questions seem to be sort of linked to some extent. Hugo, did you want to present those?
Sure. Why palatoglossus muscle involvement in oropharyngeal cancer don't make it T4? And there is also another question, maybe kind of related. Why extrinsic muscle involvement makes oropharyngeal cancer inoperable? I think for Dr. Zaid.
Yeah. Palatoglossus and extrinsic tongue muscles.
I think probably Gitta can answer that as well, because we always have a debate about what you call a T4 and a small T4. There is a bit of what's called the double-edged sword. You can overstage, which sort of helps with your numbers. Palatoglossus, which is effectively the anterior tonsillar pillar, is still very resectable. It's on the surface, and it's quite, I think, reasonably easy to distinguish when it's involved or not, even clinically. And it's going to come out whether it's, usually that's in oropharyngeal cancer. Extrinsic tongue involvement, if we're talking about oropharyngeal tumors, then that is, I think, quite a tricky area, because then that's when the disease dives into the glossotonsillar sulcus, which we believe most probably of the unknown primaries start. And actually, Gitta sometimes looks at that as well with the ultrasound, and picks certain things in the tongue base and that have not been otherwise identified. But then if we're chasing disease from the inside out, it becomes very difficult to get a clear margin. And as I said, the last thing you want is to escalate treatment in a perfectly reasonably curable disease and end up with a very poor functional outcome. I think everybody, when they start a new operation, as I'm probably the minority here as a surgeon, I can say that you start something, you're kind of quite eager and you want to increase the numbers. And if you're recruiting to trials or something, there's lots of motivation in that, and you want to make something work. But with time, you become more and more selective, because you learn what works and what doesn't work. And you've already, I think, transoral robotic surgery, it has been already established. I don't think it's going to go away. We do it within and outside clinical trials at the moment, but I have to say, I think we're a bit more selective than other places. Is that fair to say, Gitta?
Yes, definitely. And I mean, I think we're very wary of stage migration in my MDT. So we used to have an oncologist who really you would have to have really quite substantial extrinsic muscle involvement in the old TNM7 staging to allow you to upstage it. And I think it is a way of looking at things that trying to make the staging consistent. Obviously, it doesn't go along with updates in TNM staging, which we kept pointing out that actually, if we were going to just stage it the way we always did, why do we bother updating the TNM staging? So I think there is a balance, and I do see people who report, a tumor being very close to extrinsic tongue muscle and, maybe abutting it and then suggesting that upstages. So I think there is a balance to strike, although it's nice to be able to pick up subtlety, but it has to be definitive. So, but I mean, I think I would say small amounts of extrinsic tongue muscle involvement is operable, isn't it, Zaid? It just depends on the extent.
It is, exactly. I think as long as you're very clear that this is going to be, so I do additional resections on all tongue muscles with robotic resections, and again, it's a matter of trust. So, and that is a working relationship you establish with the members of your team, with your radiologist and with the histopathologist, and obviously with the oncologist, and that only comes with time. And I think that's when working together for a long time helps. And there are certain things which we do not have the answer to, and you just go by what you know in your own experience. There's certain areas. So, ideally, every single patient for surgery will have to undergo. I think we do pretty much everyone examination under anesthetic before, robotic resection. You don't want to have a surprise on the day when the patient can't open the mouth enough, or they're retrognathic, or the equipment doesn't fit. Then the whole thing is pointless. But yeah, I think what I was trying to say is that there's some series, and especially, for example, when I looked at the pathos recruitment numbers, there are lots of units who get a lot earlier disease than we do. So you get stage 1, and 2 disease. In my experience, I think I had 2 patients with stage 1 and 2 disease, as in with no nodal involvement, and small T1s and T2s, and everybody else had definitely nodal involvements. We had small primaries, no question about it, but I definitely don't push it. I think T3, in my experience, as long as it's not just because it's an exophytic tumor, is a bit of a push for transoral resection in terms of it's removable. It's just in terms of the functional outcome after that. We have our own series, which is about to hopefully be published, and we looked at those who needed reconstruction, those who didn't need reconstruction, and the function. But the trials have also published, including Orator, the functional outcome of surgery is not that much better than non-surgical treatment, and I think people have got to face up to that.
It's incredibly helpful. Thank you very much indeed. So I think we're pretty much coming up to time. Thank you so much to both of our speakers, Dr. Gitta Madani and Mr. Zaid Awad. Fantastic contributions. Thank you very much. Over to Salman. I think we wanted to have a couple of words.
Yeah, no, I mean, thank you. Excellent talks, Gitta and Zaid. Thank you, Phil and Hugo, for moderating. Just want to also thank Colleen from the ASHNR office for organizing everything, Mailan, my counterpart on the American side. So we'll keep you posted with details of the next webinar. So take care, enjoy the rest of your evening, day, afternoon, wherever in the world you are. Take care. Bye-bye.